Welcome back to the deep dive. Today we are shifting gears completely. We're leaving the world of casual curiosity and, well, we're entering the war room.
A good way to put it.
I want you to picture this scene. It's 2 in the morning. The coffee pot is empty. You're a postgraduate resident in anesthesiology.
We've all been there.
Your desk is just groaning under the weight of Guyton for physiology, Miller and Morgan for anesthesia, and of course, Katie Tripathi for pharmacology. And you're staring at a past paper from Gujarat University, and there it is, the long question.
The 20 marker.
The 20 marker that decides your fate.
Is a scenario I know well, and frankly, it's a scenario that separates the students who've just read the summary from the students who truly understand the mechanism.
And the topic we're tackling today is a perfect example of that.
Absolutely. We're going deep on the hypothalamo-pituitary organ axis with a special focus on acromegaly and its anesthetic implications.
It's a beast of a topic. I mean, it bridges basic neuroscience, endocrinology, airway management, and critical care. It's everything in one question.
It is.
So for this session, I'm going to be that exhausted resident trying to connect all these dots. And you're my senior faculty. You're the examiner.
Okay.
You're the one who's going to tell me exactly what I need to write to get those 20 marks.
I can certainly do that.
Yeah.
And I'll tell you right now, if you get this topic... logical. But, and this is a big, but it's also a minefield, if you miss the basic physiology, you cannot explain the pathology.
And if you can't explain the pathology...
your anesthetic management plan will look unsafe. And in the exam, safety is everything.
Okay, let's unpack this. We have a massive outline to cover, starting from the absolute basics of physiology and ending with post-op ICU care. Let's start with Part A, basic physiology of the HPO axis. How do I even begin the introduction for a 20-mark answer?
You start by defining the battlefield, the hypothalamo-pituitary organ axis, or HPO axis.
Yeah.
You have to state that it's essentially the master coordinator of the body.
Right, the link between the nervous system and the endocrine system.
Exactly. It's that neuroendocrine circuitry. You need to explicitly state its role in homeostasis, maintaining the internal environment, and, crucially for us as anesthetists, its role in the stress response.
Right, because when we induce anesthesia, or when the surgeon even makes the first incision, what we're really managing is the body's stress response.
Precisely. The HPO axis coordinates the release of catecholamines, cortisol, ADH, all the big players. If this axis is dysfunctional, or if it's hyperactive like we see in acromegaly, the patient's hemodynamic stability is completely compromised.
So the intro has to link the textbook science to the bedside.
It must. You have to show the examiner you understand why the physiology matters.
Okay, let's zoom in on the CEO of this whole operation, the hypothalamus. Anatomically, where are we?
We're in the dientencephalon. For the exam, you must visualize it. The hypothalamus forms the floor and the lateral walls of the third ventricle.
And you need to know the boundaries to impress the examiner, right?
You do. Mention the optic chiasm interiorly and the mammillary bodies posteriorly. It shows you have a clear mental map.
And it's not just one single blob of tissue, it's a collection of different nuclei.
Correct. Think of it as a processing center. It's getting inputs from the limbic system, which processes things like fear and anxiety, and from the autonomic nervous system.
And it turns those electrical signals into chemical messages?
That's the key. It converts nerve signals into hormones, specifically releasing hormones and inhibiting hormones.
Okay, let's list the high-yield ones for the exam. I know we've got TRH and CRH.
Thyrotropin-releasing hormone, TRH, and corticotropin-releasing hormone, CRH. CRH is absolutely vital for us because it kicks off the whole adrenal stress response.
What else?
Then you have GnRH, gonadotropin-releasing hormone, and GHRH, which is growth hormone-releasing hormone, the star of our show today.
And the inhibitors, the ones that put on the brakes.
The two big ones are somatostatin, which inhibits growth hormone, and dopamine, which inhibits prolactin.
Now, here's the concept I remember being tricky. How do these hormones get to the pituitary? They don't just, float around in the general circulation, do they?
No, they don't. And you must explain this clearly. They use a shortcut.
The portal system.
The hyperthalamic hypophyseal portal system. This is exam gold. You have to describe it. Blood flows from the median eminence of the hypothalamus directly down the pituitary stalk to the anterior pituitary.
And that direct line means the hormones are super concentrated when they arrive.
Exactly. It ensures these releasing hormones arrive in high concentrations. If they went through the whole body, they'd be far too diluted to work effectively. It's a direct, high-priority communication line.
Okay, so moving down that communication line, we hit the pituitary gland. The master gland, or maybe the general manager?
It sits in a very special location, the sella turcica of the sphenoid bone. Now, pay close attention here because this anatomy dictates all the surgical risks we'll discuss later.
The bony saddle.
Yes. The gland is roofed by the diaphragma celli, which is a fold of dura mater. But what lies on either side of it laterally?
The cavernous sinus.
The cavernous sinus, exactly. And inside that sinus, what do you have?
The internal carotid artery and some cranial nerves, 3, 4, and 6.
Perfect. 3, 4, and 6. So if a surgeon goes a little too wide during transsphenoidal surgery,
They could hit the carotid and cause a massive hemorrhage or knock out eye movements with a nerve palsy.
mentioning that specific relationship in your anatomy section shows the examiner you're thinking like a clinician, not just a textbook reader.
Okay, let's break down the hormones. Anterior versus posterior pituitary.
The anterior pituitary, or adenohypophysis, is the factory. It synthesizes and secretes hormones. You have 5 major cell types producing 6 major hormones.
Let's run through them.
First, the acidophiles. You have somatotropes making growth hormone and lactotropes making prolactin.
And then the basophils.
Right. Corticotropes make ACTH, thyrotropes make TSH, and gonadotropes make FSH and LH.
Okay, so that's the factory. What about the posterior pituitary?
The neurohypophysis. It's a completely different concept. It's not a factory. It's a warehouse.
A storage unit.
Precisely. It stores hormones that were actually synthesized upstairs in the hypothalamus, specifically in the supraoptic and periventricular nuclei.
And they travel down nerve axons to be stored.
Yes, exactly. To be stored in the posterior lobe until they're needed.
And the key players there are oxytocin and, for us, ADH.
ADH, or vasopressin, is the one we obsess over in the ICU and OT. It acts on V2 receptors in the kidney to retain water and V1 receptors in the vasculature to cause vasoconstriction.
So if the pituitary stalk is damaged during surgery,
The supply chain is cut, no ADH gets released, and that leads to diabetes insipidus.
we will definitely do a deep dive into DI later. But first, let's talk regulation. The feedback loops. This is core physiology.
Think of a thermostat in your house. The hypothalamus sends a signal, PRH. The pituitary amplifies it, sending out TSH. The thyroid, the furnace, executes the order by releasing T3 and T4.
And when the room gets warm enough, when T3 and T4 levels rise,
They circle back and tell the hypothalamus and pituitary to cool it, to turn off. That's your classic negative feedback.
but in our line of work during major surgery, trauma, sepsis, this loop behaves differently, doesn't it?
It gets overridden. This is a critical concept, the stress response. Even if your cortisol level is sky high, the body knows it's under attack during a major operation. So it just keeps pumping out CRH and ACTH to mobilize glucose and maintain blood pressure. The thermostat's safety override is on.
Okay, I think that covers part A pretty well. Now let's focus on the star of today's show, growth hormone. Why is GH so absolutely critical for the anesthetist to understand?
Because its dysregulation leads to acromegaly, which is without a doubt one of the most complex airway challenges in all of anesthesia.
And to understand the abnormal, we must first master the normal.
Exactly. GH regulation is a constant tug of war. You have GHRH from the hypothalamus, which is stimulatory.
Accelerate.
Yes. And then you have somatostatin, which is inhibitory. The brake, the ballast between these two, dictates GH release.
And it's pulsatile, isn't it? Not just a steady stream.
Very pulsatile. The old wives' scale, if you don't sleep, you won't grow, is physiologically spot on. The massive pulses of GH occur during deep, slow-wave sleep.
So does GH do all the heavy lifting itself?
It does some, but it delegates a lot of the work to the liver. GH is the manager. It goes to the liver and stimulates it to produce IGF-1.
Insulin-like growth factor 1, also called somatomedin C.
Correct. And IGF-1 is the real contractor that goes out and actually drives bone and cartilage growth.
Okay, let's talk about the metabolic effects. This is huge. I've heard GH described as an anti-insulin hormone.
That is a very high-yield concept for your exam. GH is fundamentally diabetogenic.
Diabetogenic.
It wants to keep fuel available in the blood for growth. So it does a few things. It decreases glucose uptake by cells, which causes hyperglycemia.
So it makes you insulin resistant.
Highly insulin resistant. It also breaks down fat, that's lipolysis, to increase free fatty acids for energy. But it's also anabolic for proteins. It helps build muscle.
But for the anesthetist, the big flashing red light is that a patient with excess GH is going to be insulin resistant. They'll behave like a brittle diabetic in the operating room.
You've got it. And that brings us perfectly to Part C, acromegaly, the clinical application of all this physiology we've just covered.
So, definition for the exam.
Acromegaly is a clinical syndrome caused by excess growth hormone and, by extension, IGF-1 after the closure of the epiphyseal plates in adulthood.
And if it happens before the plates close in a child?
That's gigantism. The long bones can still grow longitudinally, so the child becomes incredibly pathologically tall. In adults, the plates are fused.
So the bones can't get longer.
They can't, so they get thicker. They grow wider. Acral growth.
And the cause is almost always a tumor.
In 99% of cases, it's a pituitary adenoma, usually an acidophilic tumor of the somatotrophs, the GH-producing cells.
And this is basically a failure of that feedback loop we just discussed.
A total failure. The tumor secretes GH autonomously. It completely ignores the somatostatin brake signals from the hypothalamus or the negative feedback from high IGF-1 levels.
Yeah.
It just keeps on secreting.
Okay, so we have an adult patient with unchecked, continuous high levels of growth hormone. Pathophysiologically, what is happening to their tissues?
You need to break it down into two main processes for your answer: bone overgrowth and soft tissue overgrowth.
The bone growth causes the classic features.
Exactly. The prognathism, that jutting, prominent jaw, and the prominent suborbital ridges, the big forehead. But for us, for the anesthetist, the soft tissue overgrowth is the real killer.
Because it's everywhere.
Everywhere. It affects the skin, the connective tissue, the tongue, the heart, the vocal cords, the pharynx. Everything gets bigger and thicker.
Let's dive deep into that. Part D, systemic effects of acromegaly. This is the absolute core of the clinical answer. If I'm writing this out, where do I start?
You start with the airway. Non-negotiable. Acromegaly is synonymous with difficult airway. But you can't just write that. It's too vague. You need to list the specific anatomical levels of difficulty.
Okay, so the big four. Level 1, the face.
Prognathism. The mandible grows forward and protrudes. This completely changes the geometry of the face, making a good mask seal incredibly difficult. You just can't get a grip.
Level 2, the
Macroglossia. The tongue is not just large, it is massive. It's muscular and it's infiltrated with connective tissue. It fills the entire oral cavity. So when you insert a laryngoscope blade,
You have nowhere to sweep the tongue. It just obstructs your view of the glottis.
it obstructs everything. You see a wall of pink.
Okay, level 3, the pharynx.
The soft tissues of the pharynx, the uvula, the epiglottis, they're all thickened and enlarged. The epiglottis is often described as huge and floppy. This narrows the entire pharyngeal space. And it's why almost all of these patients have significant obstructive sleep apnea, OSA.
And then there's level 4, the one that's so often missed in exams.
Subglottic stenosis. This is the trap. The cricoid cartilage itself can hypertrophy, and the mucosal lining inside the trachea thickens. This means the narrowest part of the airway might be below the vocal cords.
Wow.
So you might successfully visualize the cords, you might even pass the tube through the cords, but then it gets stuck in the subglottis.
That is a terrifying scenario. A true can't intubate, can't ventilate situation waiting to happen.
It is. And it has major implications for your choice of endotracheal tube, which we'll discuss in management.
Okay, let's move from the airway to the cardiovascular system, another very high-yield section.
Acromegalic cardiomyopathy. This is a specific disease entity. You must state that. It is not just heart disease secondary to hypertension. The excess GH causes direct fibrosis and hypertrophy of the myocardium.
So muscle is replaced by stiff, fibrous tissue.
Exactly. The heart becomes thick and stiff, so you get diastolic dysfunction very early on. The heart can't relax properly to fill with blood.
And on top of that, you have hypertension.
Yes, it's very common. The mechanism is twofold. GH acts on the renal tubules to retain sodium, so you have volume overload. And you also have increased systemic vascular resistance.
So you have a stiff, overworked heart under high pressure, prone to failure. What about arrhythmias?
Very common. The fibrosis disrupts the normal electrical conduction pathways in the heart. You need to be vigilant for conduction defects on the ECG, ventricular ectopics, the whole range.
Okay, let's quickly cover the metabolic and skeletal effects to round out the systems.
As we mentioned, diabetes mellitus is rampant due to that profound insulin resistance.
That's a Galatol.
Look for kyphoscoliosis. The spine creates new bone, which can cause significant curvature. This can further compromise respiratory mechanics, adding a restrictive component to their lung disease on top of the obstructive element.
And what about peripheral nerves? I remember reading about carpal tunnel syndrome.
Yes, it's very common. The soft tissue in the carpal tunnel swells and compresses the median nerve. Now, why does an anesthetist care about that?
Because if you're placing an invasive arterial line in the radial artery,
You must check for good collateral flow with an Allen's test. The median nerve is already compromised. The last thing you want to do is add an ischemic injury to it from a poorly placed or thrombosed arterial line.
Okay, we have the physiology and the pathology down. Now let's put on our scrubs. Part E, anesthetic implications. I'm seeing this patient in the preoperative assessment clinic. What am I looking for?
You are being a detective. Start with the history. Ask specifically about snoring, daytime sleepiness, witnessed apnea, screen aggressively for OSA. Ask about exercise tolerance to gauge that underlying cardiomyopathy.
Is there a good trick to assessing how rapidly the airway has changed?
Yes. Look at old photographs. Ask the patient to show you their driver's license or a photo from 10 years ago on their phone. Compare their facial features. If the change is drastic and recent, the airway changes are likely to be just as severe.
And the physical exam.
Don't just look. Test things. Ask them to protrude their mandible. Can they even create an underbite? Often they can't. Listen to their voice. Is it deep, resonant, and hoarse? That suggests thickened vocal cords. Palpate the neck for a goiter, as organomegaly affects the thyroid too.
And what investigations are non-negotiable?
Beyond the standard labs, you need an ECG to look for LVH and arrhythmias. You need an echocardiogram to formally assess that diastolic function and wall thickness. You need recent blood glucose levels. And importantly, you must check their visual fields.
Why visual fields? What's the anesthetic relevance?
Remember the anatomy of the sella turcica. The pituitary sits right under the optic chiasm. A large tumor pushes up and compresses the chiasm from below,
Causing bitemporal hemianopia.
tunnel vision, essentially. Loss of peripheral vision. If they have this sign, it implies a large suprasellar extension of the tumor, and that means you have to be concerned about raised intracranial pressure.
Okay, assessment done. Now for the big one. Anesthetic management. Let's talk about the strategy.
Let's talk about the elephant in the room, or rather the acromegalic in the room, the airway strategy. The expert rule, the thing you must write in your exam is anticipate difficulty.
And plan A?
Plan A for a known acromegalic patient with clear airway features is awake fiber optic intubation, AFOI.
Why is AFOI the gold standard here? Why not just go straight to a video laryngoscope?
Video laryngoscopy is a fantastic tool, but it doesn't solve the fundamental problem of soft tissue collapse upon induction of anesthesia.
So if you put them to sleep and paralyze them.
The massive tongue and all that redundant pharyngeal tissue collapses. You can very easily find yourself in a can't intubate, can't ventilate scenario. And a surgical airway, a cricothyrotomy, is incredibly difficult because the neck tissues are thick and fibrous and the landmarks are completely distorted.
So the safest approach is to secure the airway while they are still conscious and breathing spontaneously.
Correct. Use topical local anesthesia, maybe some gentle sedation, keep them calm, pass the scope, see the cords, thread the tube. Once the tube position is confirmed with capnography, then you induce general anesthesia. It is the safest answer for the exam and for the patient.
What about the endotracheal tube size?
Downsize. Always downsize. Remember the risk of subglottic stenosis. If it's a large man who would normally take a size 8.5 or 9.0 tube, you should have a 7.0 or 7.5 ready. Don't force the tube.
Because the mucosa is friable.
Extremely. The nasal and pharyngeal mucosa in acromegaly is friable and highly vascular. It bleeds if you just look at it wrong. You do not want to turn a difficult airway into a bloody, impossible airway.
Okay. Monitoring-wise, what's essential?
Invasive arterial pressure is usually indicated, given the cardiac comorbidities and the potential for hemodynamic swings during surgery. Neuromuscular monitoring is mandatory. Some acromegalics can have a proximal myopathy, which can make their response to muscle relaxants unpredictable.
Let's move to the surgery itself. Part F, pituitary surgery context. This is almost always done transsphenoidally now, right?
Yes. Through the nose, through the sphenoid sinus, up to the floor of the sella.
What are the specific intraoperative concerns for the anesthetist?
First, the surgeon will infiltrate the nasal mucosa with a potent vasoconstrictor, usually adrenaline mixed with local anesthetic, or something called Moffitt's solution.
And that causes a huge hemodynamic spike.
A massive one. You will see the heart rate and blood pressure shoot up. In a patient with a stiff cardiomyopathic heart, this can easily precipitate myocardial ischemia or acute heart failure. You need to be ready with short-acting beta blockers or vasodilators, and you need to communicate clearly with the surgeon before they inject.
Okay, what else? Positioning.
The head is usually elevated to decrease venous congestion and bleeding. Just be mindful of the theoretical risk of venous air embolism, though it's much lower than in sitting craniotomies.
And the throat pack?
Crucial point for the exam. The surgeon places a gauze pack in the pharynx to catch blood and bone chips. You must, and I mean must, ensure this is removed before extubation.
It's a never event.
It is. A retained throat pack causes complete airway obstruction and can be fatal. Write it on a whiteboard in the OR. Make it part of your formal count. Do not forget it.
Okay, surgery ends. The tumor is out. It's time for extubation.
This is an extremely high-risk phase. The airway might actually be worse now than when you started.
Why?
Surgical edema, venous congestion from the head-up positioning. The tissues can swell significantly.
So, no deep extubation.
Absolutely not. The patient must be fully awake, following commands, with full return of their reflexes and muscle power. Sit them up as much as possible, and have an airway exchange catheter or a full reintubation kit immediately at hand. Be prepared to reintubate.
Now, they're in the postoperative care unit or ICU. What are we watching for, like a hawk?
Airway obstruction is still risk number 1. Remember, their nose is now packed with gauze, so they are obligatory mouth breathers. If they have underlying OSA, it will be severe now. You must monitor their oxygenation and respiratory rate very closely.
And then the hormonal complications. This is where all that early physiology comes back to haunt us.
Yes. The big one is diabetes insipidus, DI. If the surgeon has traumatized the posterior pituitary or the pituitary stalk, the supply of ADH can suddenly stop.
And the signs are?
Polyuria. Dramatic polyuria. They start passing huge volumes of dilute, clear urine 300, 500, even 1,000 milliliters per hour.
And the serum sodium starts to climb. Hypernatremia.
Exactly, because they are just losing free water.
And the treat.
You replace the fluid, usually matching the urine output volume for volume, and you get pharmacological replacement with desmopressin or DDAVP. But you have to be careful.
Why careful?
Because the damage might be temporary. Sometimes you get what's called a triphasic response. First DI, then the dying neurons dump all their stored ADH at once, causing the opposite problem, SIADH, syndrome of inappropriate ADH.
And then they retain water and become hypernatremic.
Right, and then it can revert back to DI again. You have to watch the fluid balance chart and the electrolytes like a hawk for the first few days.
One last complication to mention.
The CSF leak. If the diaphragm sellae was breached during surgery, cerebrospinal fluid can leak into the sphenoid sinus and then out through the nose. Rhinorrhea. If you see clear, watery fluid dripping from the nose, you have to suspect it.
And that's a huge risk for meningitis.
A massive risk.
This has been a tremendous amount of information. Let's try to bring it all together for Part G exam integration. The listener is in the exam hall. They have 30 minutes to write this answer. How do they structure it to get the marks?
Structure is what gets you the marks. Do not just write a wall of text. Use clear headings.
So what's the flow?
1. Introduction. Define the HPO axis and acromegaly. Mention the stress response link. 2. Anatomy. Briefly describe the hypothalamus and pituitary. Crucially, draw the sella turcica and label the cavernous sinus relations. That gets marks. 3. Physiology. Draw the H-Kinsey feedback loop. Mention the portal system. 4. Pathophysiology and systemic effects. This is the bulk of it. Go system by system, airways, CVS, metabolic. Use a table here if you can. 5. Anesthetic management. Break this into 3 clear subheadings: preoperative assessment, intraoperative management, and postoperative care.
You mentioned a comparison table. Examiners love tables. What should be in it?
Compare normal GH physiology versus acromegaly. It's a great way to show you understand the core concepts.
Okay, give me some examples.
Column 1, normal. Column 2, acromegaly. First row, secretion is pulsatile, mainly at night. For acromegaly, constant, high-level, non-pulsatile secretion. Second row, regulated by feedback. For acromegaly, autonomous secretion fails suppression tests. Third row, stimulates linear growth in children. For acromegaly, stimulates acral and soft tissue growth in adults. Fourth row, insulin sensitivity is maintained. For acromegaly, causes severe insulin resistance.
Perfect. Now, what about the Viva? You're the examiner. What are the common traps you set?
The biggest trap is the airway. Always, if I ask, why is the airway difficult, and you only say they have a big tongue, you will get average marks. To get honors marks, you must mention prognathism and its effect on the mask seal, and subglottic stenosis and its effect on tube selection.
What's another one?
How do you extubate this patient? The trap answer is, I'd do a deep extubation to avoid coughing and raising ICP. That's an unsafe answer. The correct answer is, this is a high-risk extubation. The patient must be fully awake, sitting up, with an airway exchange catheter in place because the risk of airway compromise is too high. Safety always trumps physiology in that scenario.
Diagrams.
A picture is worth 1,000 words, and about 5 marks in a long question.
What are the 2 essential ones here?
1. A simple schematic of the HPO axis showing the negative feedback loops. 2. A cross-section of the sella turcica showing the pituitary, the cavernous sinus, and the internal carotid arteries. Shows you understand the surgical danger zones.
This has been a marathon session. Let's summarize it all. Give us the exam conclusion, the final bullet points to memorize just before walking in.
Okay, here is your high-yield recap.
Hit me.
1. The HPO axis regulates homeostasis via the portal system. The hypothalamus is the CEO, the pituitary is the manager. 2. Acromegaly is XSGH and IGF-1 in adults, usually from a pituitary adenoma. 3. Physiologically, it causes insulin resistance, leading to diabetes and a specific cardiomyopathy due to fibrosis. 4. Anatomically, it destroys the airway at multiple levels: prognathism, macroglossia, pharyngeal thickening, and subglottic stenosis. 5. Anesthetically, you must anticipate a difficult airway. AFOI is the gold standard for intubation. And 6. Surgically, watch for the adrenaline spike, always remove the throat pack, and monitor vigilantly for diabetes insipidus and CSF leaks postoperatively.
That feels incredibly comprehensive. It really connects the molecular biology right to the moment you're standing at the head of the bed holding a laryngoscope.
That is the beauty of the topic. It demands you be a complete physician. If you approach it systematically, anatomy, then physiology, then pathology, then management, you will not only pass the exam, you'll be ready to handle these challenging patients safely in real life.
And I think the key is to visualize the patient. The large hands, the prominent jaw, the deep voice. If you can keep that clinical phenotype in your mind, the physiology just makes sense.
Absolutely. So to all the residents preparing for the Gujarat University exams or any anesthesia exams, good luck. Go in there confident, draw your diagrams, and always prioritize safety.
Thanks for the masterclass. We will catch you on the next deep dive.
Who crushed that paper?